The following presentation discusses the causes, presentation, diagnosis, and treatment of secondary shoulder impingement. Shoulder impingement was first described by Dr. Charles Neer in 1972. He described it as mechanical impingement of the rotator cuff tendons beneath the antero-inferior portion of the acromion. This definition has since expanded to encompass all structures associated with the subacromial space. There are two types of impingements discussed by the shoulder joint. Primary impingement, which Neer described, occurs when the structures between the greater tuberosity of the humerus and the coracoacromial arch become impinged or damaged due to diminished subacromial space. In secondary impingement, however, impingement occurs due to joint instability, laxity, and poor motor control. A simple way to think of it is that in primary impingement, structures are impinged due to a decreased anatomical space, whereas in secondary impingement, structures are impinged due to excess translation of the humeral head and/or scapular dyskinesia. First, let's get a better understanding of the anatomy. So what is the coracoacromial arch? The arch consists of the coracoid process anteriorly, the acromion posteriorly, and the coracoacromial ligament superiorly, which bridges the two. The muscles of the rotator cuff work dynamically to hold the humeral head neatly within the glenoid fossa. These muscles include the subscapularis anteriorly, the supraspinatus superiorly, and the infraspinatus and teres minor posteriorly. The long head of the biceps tendon courses superiorly over the humeral head and blends into the labrum of the shoulder, but is not considered a rotator cuff muscle. The subacromial bursa is a fluid-filled sac directly below the acromion and works to reduce friction between tendons and bony structures. The shoulder labrum sits within the glenoid fossa and functions to secure the humeral head within the glenoid fossa. During excessive translation of the humeral head, any one of these structures may become encroached upon or trapped and become chronically irritated or damaged. Here's a quick lateral view of the glenoid fossa and its surrounding structures.
This condition is so prevalent in overhead athletes, we found this patient population to be a great example to explain the mechanism of injury that occurs with secondary impingement. Often the athlete will attain a tight posterior capsule, the reason for which is not totally understood at this point in time. However, the tight posterior capsule and inferior capsule will limit the athlete from attaining full external rotation with normal glenohumeral biomechanics and forces the humeral head to shift anteriorly and superiorly to attain the rate of motion that they need. This causes internal impingement and increases the moment at the long head of the biceps and the superior labral complex. This is the mechanism by which these athletes often attain damage to these structures and can also be applied to overhead laborers or any other patient you see with secondary impingement. Picture on this slide is a depiction of what is described as internal impingement with excessive excursion of the humeral head. Both pictures on this slide further explain the biomechanical repercussions of the tight capsule and the external rotation for an overhead athlete. You can see on the right the position of the long head of biceps and supraspinatus during abduction and external rotation, and also on the right the subsequent damage when the humeral head has excessive movement during this movement.
As we touched on earlier, in secondary impingement, the patient is generally less than 40 years old, athletic, and either an overhead athlete or an overhead laborer. In one study, 65.1% of male overhead athletes self-reported shoulder problems, 35% of female overhead athletes self-reported shoulder problems. In this study, volleyball athletes were most commonly affected. So as you can see, this is a very common condition. Currently, there is no gold standard for a medical diagnosis. MRI can be used to verify decreased subacromial space and rule out tissue damage such as labral tears, fractures, or ligament tears that may require surgical intervention. Recently, high-resonance ultrasound has also been used to diagnose shoulder impingement, but currently, the most common method is through physical examination findings and history.
So let's move on to the physical therapy exam. When taking a history, you'll likely find that the patient's pain came on gradually, and that the patient may or may not be able to identify the initial incident. If the patient can identify it, they may describe it as sharp pain in the shoulder, suggesting possible damage to the rotator cuff or labrum. The patient will generally describe their pain as a dull ache with general use, although they can have a dull ache at rest if their impingement is severe or aggravated, and a sharp pain during aggravating overhead movements. Patients will also describe increased pain after activity, especially overhead activities. They may also report having to stop the aggravating activity because of pain. Generally, the easing factors include rest, ice, and the use of NSAIDs. Now let's look at some objective findings. During the assessment, you may find that the patient has positive impingement tests, as pictured on the next slide, positive resisted testing of the scapular stabilizers or rotator cuff muscles, and deficits in active or passive range of motion. Pictured on this slide is the painful arc, which is described as a patient's symptoms becoming markedly worse between 70 and 120 degrees of shoulder abduction, suggesting possible rotator cuff damage. Pictured on this slide are a few tests used for impingement and range of motion. The top left shows Hawk and Kennedy's special test for impingement, and the bottom left shows Neer's special test for impingement. Both are considered positive if the test reproduces the patient's familiar pain. The picture on the right describes the internal and external range of motion at the shoulder. This is important for secondary impingement, especially for the overhead athlete. With the patient in supine, the therapist will measure the patient's internal and external rotation range of motion and add them together on both left and right shoulders. Findings of less than 180 degrees of total motion on either side, or a difference of greater than 10 degrees from right to left, indicates a rotational deficit. Often, an overhead athlete will have a greater external rotation and lesser internal rotation in the dominant arm, but as long as the patient meets these standards, this finding is common and not necessarily pathological. You may also find that the patient has scapular dyskinesia and/or abnormal positioning of the scapula at rest, abnormal posture, and pain with palpation over the involved structures. So far, all the objective findings I've mentioned would not necessarily lead you to confirm that your patient has secondary impingement because so many of the findings are very similar to other shoulder pathologies. However, the next three findings are specific to secondary impingement, setting it apart from other shoulder pathologies, especially from primary impingement. You will likely find that your patient has one or all of the tests listed on this slide positive: instability tests, labral tests, and hypermobility with accessory motion. This should make sense to you when you consider the definition given earlier for secondary impingement. Pictured on this slide is the sulcus sign. The therapist is giving a distraction force at the humerus, and you can clearly see the humerus pull away from the acromion, which is considered a positive sign. Pictured on the left side of this slide is the apprehension relocation test, in which the patient is supine and the therapist passively externally rotates the arm and watches for the patient to become apprehensive. And if they do, the therapist then adds an anterior to posterior force to the shoulder joint and looks for relief of these apprehensive symptoms. This is considered a positive test. The second test, pictured on the right, is the biceps load test, in which the therapist passively externally rotates the arm and asks the patient to actively flex the elbow against the therapist's resistance. This test is positive with reproduction of the patient's familiar symptoms and suggests possible damage to the labrum. Here's a list of other conditions that may have one or more similar subjective or objective findings as secondary impingement. As I said before, many of the findings for secondary impingement are similar to other shoulder pathologies. It is important to clear the joints above and below the shoulder and to consider closely other shoulder pathologies before concluding that the patient has secondary impingement.
Patients generally respond well to conservative treatment. In the acute stage of healing, the most important thing is cessation of the irritating activity and general treatment of inflammation through rest, ice, and other modalities. Gentle stretching and active mobility within a pain-free range is also important during this time to prevent contractures or atrophy. Following the acute phase, strengthening of the rotator cuff muscles will add stability to the shoulder joint. Modern evidence-based practice now strongly recommends addressing postural abnormalities and scapular deviations. As always, treat the impairments you find, but common scapular deviations that may result in shoulder impingement include weakened lower traps, weakened serratus anterior, weakened middle traps, and/or weakened rhomboids. Tight pectoralis minor and upper traps may also contribute to scapular dyskinesia. Throughout the rehabilitation process, patient education is key. Ensure that the patient understands how behavior and posture are contributing to their symptoms, why rest is important, and why and how therapeutic exercises will benefit them. Generally, prognosis for shoulder impingement is good. Few studies differentiate outcomes between primary and secondary shoulder impingement. For general shoulder impingement, however, approximately 60 to 90% of patients will see significant improvement in shoulder symptoms following conservative treatment. The most common outcome measures used in shoulder pathology are the DASH and Quick DASH. DASH stands for disabilities of the arm, shoulder, and hand, and is a 30-item questionnaire scored from 0 to 100, with higher values indicating greater disability. The Quick DASH is an abridged version of the DASH. Other accepted tests include the Oxford Shoulder Score and the Shoulder Pain and Disability Index. Since the DASH is most common, we will discuss their MCID scores. The DASH does not self-report an MCID score, but depicted below are the generally accepted MCID scores for the DASH. The minimally clinically significant accepted score is a change of 10 points or greater. The DASH has been validated as reliable, consistent, and clinically meaningful. Here are our references, and this concludes our video. Thank you for listening.